Thank you, sir.
Good evening, everyone. It's always a pleasure to be associated with Bangladesh conferences. It's my pleasure. Today, I'm going to speak about echocardiographic assessment of pathology of fallow. The technology of echocardiography has grown by leaps and bounds and has become an essential part of diagnosis and surgical, non-surgical management of congenital heart diseases like pathology of fallow, which is most common cause of cyanotic congenital heart disease in the older children. With availability of 4D echo, CT angio have almost threatened the supremacy of the catheterization and the angiogram, which is considered as the gold standard. And today, echo can detect all the 4 anatomical abnormalities that together are called as tetralogy of fallow. That is, large malaligned non-restrictive VST with a bidirectional shunt, right ventricular outflow tract obstruction or infundibular stenosis, dextroposition at a large aorta with a septal override, right ventricular hypertrophy, but anatomical spectrum is so diverse, it includes the variants of tetralogy of fallow, with pulmonary atresia and tetralogy of fallow with absent pulmonary valve or absent right pulmonary artery or the absent left pulmonary artery or the supravalvular stenosis in nearly 25% of the cases. So 2D echo with the Doppler study permits visualization of all the 4 essential anatomical features of tetralogy of fallow. Though it is called as tetralogy of fallow, it is a monology. That means the capillary insertion of the septum leads to all these 4 things. Now here you can see that overriding aorta is seen almost over the septum. There is a large non-restrictive VST and the hypertrophy of the right ventricle is so nicely seen. So this can be seen in the parasternal long axis view or in the subcostal 5-chamber view. You can see the overriding very well. Now, all the 4 features are seen, and apart from that, in the short axis, you can see the infundibular stenosis, valvular stenosis, as well as the supravalvular stenosis. But however, when both infundibular and valvular stenosis are there, it's difficult to make out the gradient across each one of them. So, short axis shows infundibular, valvular, as well as the supravalvular stenosis, and this is how the first shape is for the valvular stenosis, and this is for the infundibular. So this is how we can distinguish. But however, if you look at an angio, the pullback tracing that you get from the main pulmonary artery to the supravalvular, valvular, and the infundibular stenosis, the pullback tracing is very accurate. Whereas in case of echo, we are not so accurate in measuring these things. So dilated coronary sinus indicates that there is a persistent left superior vena cava, and that is important to inform the surgeon so that the separate cannulation is done for that. And apart from that, we can also see whether the VST is restrictive. Most often it is non-restrictive VST, but sometimes you can see here that there is a prolapse of the coronary cusp and causing the restrictive VST. When there is a restricted VST in a case of pathology, there can be suprasystemic RV pressure, thereby causing the tricuspid regurgitation. Otherwise, the RV pressures are never transmitted to the right atrium. So this is how whether the VST is restrictive or non-restrictive has to be measured. Then coronary arterial anatomy may complicate the repair for the surgeon, and as a result, in the short axis, we have to meticulously make the study of the coronary artery. The prevalence of coronary anomalies in tetralogy of fallow is anywhere between 4 to 12%. Among the anomalous coronary arteries, 72% across the RVOT. The combined risk of encountering the anomalous coronary artery or a large conus artery crossing the RVOT is around 10%. Causing the problem during the surgery, especially when they are doing the infundibulectomy, they can cut the artery. The single coronary ostia, as you see here, a single coronary ostia, both RCA and LCA coming from the single ostia. In small children, it is very easy to trace it, whereas in older patients, it becomes difficult to trace. And in such cases, CT angio with the axial image showing the right coronary artery arising from the left is very nicely seen here, and then how it is goes through the right atrioventricular groove. The most common is the right coronary artery arising from the left anterior descending artery following and the path of the infundibulum. And this, with the volume rendered reconstruction, we can nicely see how it is crossing across the RVOT. So this is how the volume rendered reconstruction images are much better. Now, what is the importance of knowing the coronary anomalies? The presence of major coronary artery located in the infundibular region makes the treatment of the right ventricular outflow tract obstruction more complex. And awareness of coronary anomaly helps in deciding the time and the type of the operative methods. So an angiographic CT angio diagnosis of anomalous coronary artery in tetralogy of Fallot is very, very important to prevent the most fatal complication after surgery. Now coming to the pulmonary atresia, it is a different cup of tea. Here we have to see whether the pulmonary arteries are confluent or non-confluent, whether it is atretic. And you can see here that it is totally atretic. Though the confluence of right and the left pulmonary artery is there, the main pulmonary artery is atretic. So this is also important. Many times such cases are pulmonary arteries are supplied by the vertical duct. So this is the arch of the aorta, and that is the vertical duct coming directly almost from the arch. So this is how we have to detect whether it is confluent, non-confluent, vertical duct is supplied. Most often, pulmonary arteries are filled by the collaterals, and these mactas in case of tetralogy are quite huge and they are plenty, and the continuous Doppler can be made out. And apart from that, gone are the days when we used to diagnose the absent pulmonary valve or pulmonary atresia on the autopsy. But today, all this can be made out by the echo itself. So here you can see that though there is hypovolemia here, and instead of being an empty pulmonary bed, it is full. So in a case of tetralogy of Fallot, if it is full, then you must suspect the absent pulmonary valve with the aneurysmally dilated main pulmonary artery. So when we do the echo in a short axis, you can see that instead of the pulmonary valve, only the rudimentary buds are there, no valve is there, and a free pulmonary regurgitation and pulmonary stenosis. So the patient will have a to and fro murmur, and that is then you can see that pulmonary stenosis as well as the free pulmonary regurgitation, and this is a case of absent pulmonary valve. Sometimes dysplastic absent pulmonary valve may be associated with the absent left pulmonary artery, as you see here, and this is only 1.9%, or that can be absent right pulmonary artery. This is very, very rare. So absent right pulmonary artery is extremely rare, and in the echo you can clearly see that the right pulmonary artery is not the main artery, and then main pulmonary artery LPA is seen and the RPA is not there. But when the absent, sometimes when the pulmonary artery is narrow and it is very difficult to make out because we have to do the balloon dilatation or stenting beforehand, the 4D echo is very handy. Here you can see that the diffuse stenosis of the right pulmonary artery is nicely seen here. So when there is an echo, you can identify the BT shunt, and the functioning BT shunt or not also can be made out by the echo. And apart from that, when the BT shunt is there, the CT angio can show whether there is a stenosis or the blockage of the pulmonary arteries or the branches also. 3D image using the surface rendered reconstruction can show the pulmonary segment supplied by the major aortopulmonary collaterals, and also 3D rendered surface reconstruction shows which arteries are supplied by the other collaterals. So here in yellow is the mactas and the native pulmonary arteries are in the blue. So this helps for the unifocalization for the surgeon, and this is how we know we can tell the surgeon which have to be closed. Now, a clinical profile of a 10 years old person referred from West Bengal, and this patient presented with the congestive cardiac failure, and the features of florid congestive cardiac failure made me really surprised what must have gone wrong in the pathology post-operative case. So when I did the echo, I was shocked to see that Normally, post-operatively, if there is any damage to the aortic valve, the regurgitation is into the left ventricle. But here the aortic regurgitation was occurring into the right ventricle. And that is the reason the RV pressure was so high, the child had developed florid congestive cardiac failure. So here, while repairing, the whole of the aorta was not brought into the LV, and as a result, part of it was still left into the right ventricle. So the child was reoperated. Unfortunately, the child developed vegetations. Though bacterial endocarditis is extremely rare in tetralogy of Fallot, it can occur. So we must keep our mind open. So measuring the main pulmonary artery, RPA and LP are extremely important for the surgeon, and so we have to see that they have to be measured, and this can be measured in various things. And here you can see that we can measure the main pulmonary artery, RPA, LPA, and then we can take the Z-score. Depending on the Z-score, the patient can be decided for the surgery or not surgery. So echocardiography can confirm the diagnosis of tetralogy of Fallot by demonstrating the large malaligned subaortic VSD, overriding aorta, infundibulous stenosis, and the right ventricular hypertrophy. But coronary anomalies can be suspected and confirmed by the CT angio. The collaterals and vertical duct can be detected by echo, but unifocalization, the type of collaterals and pressure cannot be made out by the echo. So the CT angio with the volume lender reconstruction can demonstrate coronary anomalies. What the mind does not know, the eyes will not see, and hence it is very important to know the features of tetralogy of Fallot, the complications, the types of tetralogy, and thank you very much for your patient and kind hearing. Thank you.